Hi, my name is David Daghfal. I'm a scientific director for the Americas with Abbott Laboratories. I've been with them for 30 years and glad to be here this morning to talk about Kappa and Lambda Free Light Chains.
Hi, I'm Alexa Bisinger. I'm an emergency physician. I'm Director of Medical Affairs for the America at Abbott Diagnostics. David, thank you so much for joining me today to talk a little bit about the new Kappa Lambda Free Light Chain assay and our patients with multiple myeloma and other monoclonal gammopathies.
So Alexa, can you tell us about Kappa Lambda and the free light chains and what disease states they're associated with?
Absolutely, David.
Yeah.
So, immunoglobulins, important part of our immune system.
Yeah.
They're those proteins secreted by plasma cells,
Right.
and they are shaped like a Y. And each immunoglobulin has two heavy chains and then two light chains that are kind of glued onto those heavy chains. So plasma cells, when they are abnormal or clonal, they're producing tons of these gamma globulins or gamma proteins. So those heavy chains and those light chains. And in the normal body, in a healthy body, free light chains are always produced. There are more light chains produced than heavy chains. Okay, so you always have some free Kappa light chains roaming around and some free Lambda light chains roaming around. Those are the two kinds of light chains, the two flavors, if you will. But in a cancerous state, you have one plasma cell that's kind of gone rogue and it's a factory on overdrive. So it's producing many more free light chains than the heavy chains. Yeah, and usually either one, Kappa light chain or a Lambda light chain, because each of these plasma cells, these factories usually specialize in one. So elevated free light chains are associated with a group of disease called monoclonal gammopathies. Monoclonal meaning one clone, so one plasma cell, and gamma referring to the gamma protein, and pathos referring to a disease state. So one protein, disease state.
So what types of diseases are associated with gammopathies, and could you walk us through like the progression of those diseases?
Sure, absolutely. So amyloidosis is one of the diseases that comes to mind that's gotten a lot more attention recently. And amyloidosis, these proteins, these gamma proteins, are getting misfolded. So you can think when the immunoglobulin comes, you have this protein folding. That's what creates these 3D shapes. They're getting misfolded in a funny way, and then they're sticking on to some of the organs, whether those are lungs or hearts, and creating end organ dysfunction. So that's one time you have all this extra protein being produced and it kind of misfolded, which makes it sticky, and it's sticking on and causing problems in the organs. The other kind of spectrum of disease is a spectrum that goes to multiple myeloma. It starts usually with something called MUGUS, or monoclonal gammopathy of undetermined significance, or MUGUS for short. You can see why they shorten the name. It's quite a mouthful. And that is a precancerous state. You have kind of a rogue factory producing extra light chains of one type, but it's not causing that many problems. But it's the type where you could start to make a diagnosis, and then you want to monitor this progression to see when you need to intervene. The next stage in this disease spectrum is called smoldering multiple myeloma. So MUGUS to smoldering multiple myeloma, where you are going to have some more problems. You're going to start having evidence of end organ dysfunction, problems with the protein building up in your kidneys and making your kidneys not function well. So the International Myeloma Working Group has a list of criteria that you use for each stage of disease. And then you progress to multiple myeloma, which is a full-blown cancerous state, and it is requiring treatment. So you're going to start to intervene with corticosteroids, maybe trying to suppress some of the production of those plasma cells, maybe CAR-T cell treatment, chemotherapy, stem cell transplants, et cetera, because you're starting to cause so many problems, and these rogue factories are crowding out all the normal cells in your bone marrow.
Typical cancer.
Yeah, typical.
So how frequently do we see multiple myeloma
So
in the US or worldwide?
Yeah, that's a really great question. So the incidence has been increasing over the last 30 years. We're seeing it more commonly. We don't know why. And although it's not the most common type of cancer, it is a significant chunk of the hematological or blood-based malignancies like leukemia, lymphoma. And one of the reasons it's significant is it's often caught at a later stage.
And so what clues, what tests would you look for to kind of give you an idea, oh, this is probably something that I should look for more specifically?
Absolutely, that's a great question. And this is one of the reasons why it's caught at a later stage. A lot of the early signs and symptoms are non-specific. In terms of symptoms, people might have general fatigue or bone pain because these plasma cells are produced in the bone marrow. And on the laboratory side, you often have elevated calcium. So plasma cells crowding out the bone marrow, bones, you know, calcium's good for the bones. Bones are made of calcium. It's getting released. You have high calcium. The proteins can crowd in the kidney and make you have renal dysfunction. So you have an elevation in your GFR. And hopefully you're calculating it with cystatin C as well as enzymatic creatinine, getting an accurate measurement. You have anemia because red cells are also produced in the bone marrow. So those plasma cells are crowding them out. You don't have as many red cells. And you can have bone lesion detections. It makes kind of these like Swiss cheese. They're called lytic lesions or holes in the bone marrow.
And so what are more specific tests that are used for multiple myeloma?
That's a great question because these in themselves don't diagnose multiple myeloma. You have to have a suspicion, right? You have to have a suspicion to order a specific test, and that can be done either by primary care or hematology. So first, you have serum protein electrophoresis. You're running the serum on like a Western blot, and you see a spike, and what's called an M spike or a monoclonal spike. So that will tell you that there's an increase in these. Based on molecular weight, these free light chains. It doesn't tell you whether it's free Kappa or free Lambda. So it's non-specific, but you have this M spike, and you can also use immunofixation. But Kappa Lambda Free Light Chains, which I know we have a new test coming out, and you'll talk a little bit about today, are wonderful because whereas serum protein electrophoresis takes a long time, it's not specific to the type of whether it's Kappa or Lambda. These serum free light chain assays are used to measure either the Kappa or the Lambda free light chain and the ratio, and not only to diagnose, but also to continue to monitor the progression, which is the mainstay of treatment, especially in the earlier stages of disease, and also to monitor progression in response to treatment. So can you tell me a little bit about the Kappa Lambda Free Light Chain assay?
Yeah, so we have two assays now that are coming out. One's for the Kappa, one's for the Lambda. And they're an immunoturbidimetric assay. So that means there's an antibody, a polyclonal antibody coded to a latex particle. And that antibody can bind to the free light chains, whether they be Kappa or Lambda. And
an antibody binding to an antibody almost.
Basically exactly that, So when that happens, it kind of causes agglutination or increased turbidimetry or turbidity in the solution, which means light isn't going through the solution as easily.
It gets cloudy.
It gets cloudy,
Gunky.
Exactly, right. And so now you have a change in that light measurement, and that change is captured, and we now know the concentration of those Lambda or Kappa light chains. And so that's how the chemistry works behind the assay.
That's cool. So you're not just looking for the protein, like in the M spike, you're actually with those antibodies able to differentiate whether it's Kappa or Lambda.
Correct. And we use very little volume, somewhere between 10 to 11 microliters, something like that. And it takes 10 minutes, so it's a very quick assay.
That is quick. I'd be happy with that turnaround.
Right. A lot easier.
In the ED, let alone for a hematologist.
That's right. So it's also got a wide range, so we can measure very high concentrations and very low concentrations in one test. So you don't have to do multiple draws or multiple repeats.
That's great. I would imagine that's important because the whole point in measuring some of these is the monitoring levels get really, really high because it's cancer and it's an abnormal state.
That's correct. So quick time, 10 minutes, low volume, wider range, very sensitive. It's a good assay. specific to multiple myeloma. And so
what makes it a good assay? Tell me about that.
So yeah, typically linearity, so across the range,
Sure.
Ability to do dilutions without worrying about nonlinear dilutions. One of our strengths, let's put it that way, is you can dilute and actually get a result that's linear rather than somehow it disappears after you dilute it. And that is dangerous because then they think it's an interferent or something that's not real.
Or even a negative
or a
assay,
negative, right.
perhaps.
So dilutional linearity is very important, and in our case we have good dilutional linearity. It's concordant to the most common assay out there, so it tells you basically the same thing that the other assay says. So you have disease, you don't have disease. And it has gone through the FDA, so the FDA has said sensitivity and specificity versus the clinical picture is acceptable. So that's the key there. It's not versus another assay, it's measured against the clinical picture, because as you talked about earlier, this is a very complex disease, and so you can't really rely on one test to define that. You have to
look at the whole picture and the constellation.
So we typically advise customers to look at concordance to the clinical picture, not to other
that makes sense.
assays. Yeah.
That makes sense.
The typical reflex is, oh, I want to do a correlation to my previous assay. It's like, no, you really need to think about the clinical picture here. So we do concordances when we bring the assay in. We look at, we also try to tell them to re-baseline the patients that they're monitoring, because the values are going to be slightly different, and the physicians need to get used to this new test.
Yeah, I would think the physicians and the patients, because now with Cures 2.0, the patients are getting their assay results too, and it just takes a little time to get used to when you have a slightly different unit of measurement.
So they need to have like a comment with the results. Hey, we changed methodology. You're going to see some changes, but the concordance should be the same. It should be directionally the same. If the testing was going down with the medication, it should still be going down with this new test, that kind of thing. So
I imagine the lab wants to work hand in hand with clinicians to help us just get used to a little bit different units and monitor the test, but this sounds like a lot less work for the lab and fast. I remember those protein electrophoresis in lab. It took a long time.
Yeah. Could you give us some examples of like cases that you've seen that were kind of examples of MUGUS or the more advanced version?
Yeah, absolutely. I mean, I think some of the times I've had the privilege to see patients diagnosed and follow their treatment have been, when they've been inpatients in the hospital. I can think of a gentleman, he was about 65. He came in, hypertension. He came in for routine surgery. I think it was cholecystectomy to have his gallbladder out, and was doing routine pre-ops labs, and he had elevated calcium, which is kind of unusual. I think his renal function was normal, but the thing was he had elevated calcium and he had this persistent proteinuria, so persistent high protein in his urine. So that prompted a workup, and he was found to have an M spike in his protein electrophoresis, which and workup with Kappa Lambda Free Light Chains by our hematology colleagues. And he was found to have elevated Kappa Free Light Chain and was diagnosed with MUGUS, so monoclonal gammopathy of undetermined significance of the Kappa type. And he continued to do well for years, actually. Was monitored by our hematologist with routine testing, continuing to monitor his Kappa Lambda Free Light Chain. And he actually didn't progress and did very well. I can think of another lady who wasn't as fortunate, caught a little bit later. She came into the ED after bumping into a telephone pole just with her arm, and was having all of this arm pain. We did an x-ray. She had a fracture of her humerus with which that kind of trauma, just bumping into a telephone pole isn't really usual. So we did a further workup on her. She also had some elevated calcium. She had an elevated GFR, indicating that her kidney function wasn't normal, some anemia, and because of this pathological fracture plus the other signs, referred her immediately to hematology. They did a workup on her, and she had elevated Kappa light chain, like over 3,000, I think, which is markedly abnormal, a very abnormal ratio of Kappa free light chain to Lambda free light chain, indicating like the Kappa is increasing disproportionately to the Lambda free light chain, and was diagnosed with light chain, Lambda light chain multiple myeloma, confirmed with bone marrow biopsy. She had 10% of these crazy Lambda factories in her bone marrow, and underwent treatment, and is still doing well with her treatment and continues to be monitored. But you know, treatment is hard, but I'm glad that it was caught, and I wish it could have been caught earlier in her. This is something I think primary care physicians, that, you know, these are things we're finding incidentally, but when you're seeing that constellation of symptoms, you could think about and order testing to increase diagnosis at an earlier stage to better monitoring and intervention.
Right.
So David, you mentioned concordance and agreement. Can you tell me a little bit more about what that means?
Yeah, the clinical studies that we did, we looked at concordance to the actual clinical picture, so to the actual disease state. So for instance, if I have a high Kappa, is it actually showing up in the patient as multiple myeloma or MUGUS or something like that?
Okay.
So as you can see from this table, as the disease increased, the results increased too, and we had 70%, depending on the type of disease state, concordance to the clinical picture. So these patients had already been looked at with IEF and with other tests. They were diagnosed, different disease, different stages, and then we were tested with the Kappa Lambda
free light
assay.
chain, and you saw if it agreed with their diagnosis.
Exactly.
And I imagine
it's level of
70%
agreement,
is
right.
probably pretty good, given
Pretty
that
decent,
it's not a one test diagnosis, but a constellation of diagnosis.
Exactly, and
diagnoses,
so we highlight to the physician it has to be all of the above, not just one.
For the myeloma working group.
Really need to look at all of the tests. On another hand, a lot of people want to look at correlation to a predicate device. We have great correlation, so 0.99, as you can see by these graphs. But there are some differences on the Lambda side between us and our predicate device, if you want to call it that. Tell me more about that. What differences? So there's almost a twofold difference between our Lambda and the predicate device Lambda. And the reason for that is we believe there's been a drift over time in calibration values, which has been published recently by Mayo Clinic repeatedly, actually. And the concept is if your calibration is shifting, your values might be shifting with it.
Wait, so if your calibration is, you want your calibration to be constant, right? Because that's what your base lining on and remain steady, and I bet that would be especially important for trending something sensitively
for monitoring
over
things,
time.
Yeah, it's important to have stable calibrators, and that's one thing that we pride ourselves. This assay has very stable calibration.
I imagine that's key, just to consistent results, and then the consistent ratio as well.
Correct. So in kind of an overall summary, our sensitivity and specificity are equivalent, if not a little bit better than other assays in the market. And really the important piece here is specificity of the assay being very specific to Kappa and to Lambda, not picking up other things, other IgGs or IgMs or whatever. But very specific to the light chains.
So you're not having false positives in patients that might have other immune disease, other antibodies, other inflammatory states. Is that what you're saying?
That's right. So,
that sounds like a fantastic assay. So it's quick, like 10 minutes in the lab.
10 minutes.
You're not sitting there diluting. I don't know. Maybe the laboratorians love doing this dilution. I don't know. That's why I'm not. That's why I'm not in the lab, and I thank them for doing that work for me.
We like to have it automated, have it quick, and have it not have too many reiterations of it.
Little amount of blood. Fast in the lab. It's specific and It sounds like a fantastic way to continue monitoring. But as folks are shifting assays, say, from an outside assay to this Kappa Lambda, or bringing it in for the first time, what are some of the things about method switching, some tips you have?
The key thing would be to do a concordance, not a correlation.
Okay.
To concord to the disease state. So look up what's the diagnosis, and then does this match the diagnosis?
Yep.
To re-baseline patients that are already being monitored.
Sure.
And give the physician a warning. Hey, we are changing methods. We're going to be re-baselining, so you'll see 2 values each time.
And I'd probably want to know why you're re-baselining and get used to it and know that it'll be steadier from that point on.
Right. And make sure things are tracking and trending in the same direction.
Sure.
And then you should be good to go. Yeah. Well, thank you so much. That's helped me. I hope it helps those who are watching. So if there's any further information that's needed, they can call us, right? Or call their representative for Abbott. And
I appreciate you and all of the education you do for laboratorians.
Yeah.
They make everything so much less messy for us on the clinical side. And, those diagnostic tests are
getting better.
really important and getting better.
Yeah. Well, thank you.
Thank you so much.